Now coming to the RFA, which is called radio frequency ablation of the accessory pathway. It is a non-surgical approach to eliminate atrial or ventricular reentrant tachyarrhythmias. It can remove the atrial and ventricular reentrant tachyarrhythmias, and it is non-surgical. In one way, you can say it is non-invasive also. Here you map the pathway and you ablate the aberrant pathway using the RFA catheter. There is a radio frequency ablation catheter with ablate the aberrant pathway. Catheter ablation is usually done in bothersome refractive arrhythmias. Another important thing to do catheter ablation is you should have the pathway or the focus which is amenable to ablation. Here the most important thing is that particular focus in which arrhythmias is coming should be amenable to ablation. The instance of such arrhythmias is 1 in 250 to 1000 children and usually present later in childhood. Up to 50% of adults with congenital heart disease develop supraventricular tachycardia. Now coming to the procedure of radiofrequency ablation, although right-sided pathway are easy to access, whenever you have a pathway in the right side, it is easy to access through the superior vena cava and inferior vena cava and go to the right side of the heart. But although it is easy to access, the left-sided pathway that requires transseptal rupture has a better cure rate. For going into the left side, you have to puncture the interatrial septum and go to the left side. That left-sided pathway ablations have better cure rate than right-side ablation. Electrophysiology catheters are usually introduced to the femoral vein in pediatrics. They go with the femoral vein in pediatrics. Catheter tip are positioned in right atrial appendage, bundle of His, right ventricular apex and coronary sinus. This was mentioned before. These are the 4 areas where you position the sensory catheter. Occasionally, right internal jugular venous axis is used to place the coronary sinus catheter. Rapid atrial pacing and sometimes isoproterenol infusion is required to induce the arrhythmias. You pace at a fast rate or you give bolus of isoprenolone to induce arrhythmias. Here, this is the SA node and the AV node, and you have the right and the left bundle, and this is the Purkinje fiber. This is the normal conduction pathway. And the sensory catheters are placed in the right atrium, right ventricle, coronary sinus and the bundle of His. These are all the places where you place the sensory catheter. And the ablation catheter, which is going to ablate the aberrant pathway, is located. So, you have 2 catheters. One is the sensory catheter and another is the ablation catheter. This is the angiographic view and this is the bundle of His catheter, coronary sinus catheter and the right ventricular catheter, and this is the ablation catheter which carries the current. And you can see the ablation catheter which can be used to ablate the aberrant pathway. The sensor catheter map the conduction system where the pathway comes from, and the ablation radiofrequency catheter ablate the pathway using radiofrequency energy between 300 to 750 kilohertz. Apart from radiofrequency therapy, you can use cryotherapy. Here, use cryotherapy because it can limit the damage to the atrioventricular node. If the damage to the atrioventricular node with cryotherapy is less than the radiofrequency ablation. So, you can use this in complex cases or cases in which the pathway isn't near to the AV node. An advantage of cryotherapy includes slower burn, ability to stop the ablation if there is transient AV block, and ability to stop the ablation if lengthening of PR interval occurs. These are all the advantages of cryotherapy.